I'm very excited today to have on the Reality Pill my new partner at the Beverly Hills Center for Plastic and Laser Surgery, and that's Dr. Robert Cohen. Dr. Robert Cohen is from Scottsdale, Arizona, originally, where his practice is by far one of the busiest and most successful there. And lucky for me, he's moved towards LA now. He is, as I've told many people, one of the only people I would ever actually work with. He's incredible as a surgeon, an incredible human being, a very kind person, and I truly trust him with everything that he does. He's got so much insight, so much understanding, and so much talent in plastic surgery. Today, we're not going to go into all of it. We're going to focus on a few key areas and talk about the reasoning he has behind the way he does breast implants and tummy tucks and the combination of the two, along with the risks and considerations for patients. You don't want to go into surgery blindly. You really want to pick the best surgeon possible, and hopefully we'll give you some insight on how to do that. So please welcome one of the most incredible surgeons I know, Dr. Robert Cohen.
I want to start off with the first topic is that there's a big misconception amongst patients that I see. They don't understand the difference between natural and fake versus something that makes a small difference and is subtle versus a big difference and is substantial. So what is the difference between something that's natural, something that's fake?
Right.
And can you have a big change that's natural or a small change that's fake?
Absolutely. So I think when we're talking about, for example, implants or breast size, some people sort of assume big is fake and small is natural. And that's not always the case. You know, if you go too big or too small, you can end up with an unnatural appearance. So some of the corrections, I'd say the majority of problems that I correct tend to be patients who had surgery with somebody else where they went too big. That's the most common problem. And they put implants in that don't fit the patient's body, and it can cause problems with the tissue stretching, or the implants, there's no room for them, so they can get that very humpy look up top or the breast sticking out the side. It doesn't look good. Not as common, but a problem is patients who are undersized with their implants, where they have little implants, and then you can see the two circles on the chest, but it doesn't blend with the body either. And that's a problem too, where if you go fuller, it actually fits the chest wall better. So, there's that misconception there. And then what you were talking about a second ago is, if you go, can you have a big change that looks natural or a small change that looks unnatural? Absolutely. You just posted very recently breast reduction on your feed. That was one of my cases of a very young patient. She's in her 20s who had extremely droopy and pendulous breasts. And I did a very dramatic change for her where I reduced the breasts, lifted and tightened them up. And it was a very dramatic change, but she went from sort of a very droopy, older appearance to a very natural, younger, more youthful appearance. So that was a very dramatic change. It still looked natural. Sometimes you see patients who have surgery where a little tweak is tried and it can create like an asymmetry and irregularity, and that's less natural. So I don't think it's about the the distance from point A to point B. It's more point B that matters. So some people don't need a big change to get a nice result. Other people need a very big change to get a nice result. But the end point should always be something that's natural, that fits their body, that takes their anatomy into account, rather than just choosing an implant and sticking it in, or doing a procedure that doesn't make sense for that particular patient. Every surgery needs to be customized around that specific patient's anatomy after a thorough evaluation. So just like what you do beautiful face work, and some of the cases are more subtle and some are more dramatic, but always the end goal is to have something that looks natural, because nothing stands out more than a fake or unnatural look. It just draws the eye immediately. You can tell something's not quite right.
And there's a lot of confusion I've seen because a lot of patients that come in to me for consultation, they come in confused or misled, and they base most of their understanding of what plastic surgery is just based upon bad plastic surgery. So seeing things out there that have been unnatural, that have stood out to them, and they try to take control of the situation to avoid those things. Or the contrary is that they embrace those things and they want to look fake and unnatural and weird, which does happen. So I have this conversation very often where a patient comes into me and says, listen, I just want this little tiny thing done. I don't want to look fake. I just want this done. I don't want to look fake. And I tell them, you have a poor understanding actually of what's happening. And I try to say it in a nice way. The reason people look fake is because bad surgeons do fake surgery. It has nothing to do with plastic surgery in general. You could do 20 procedures on someone's face, or in your case, on someone's body, and nobody would know that it's been done if it's left anatomically correct, meaning you put the muscle back where it's supposed to be, you put the face back where it's supposed to be, you put the nose back how it's supposed to be. You do those things where if another surgeon went in, they can't tell the difference between an operated and a non-operated nose or face, that face and nose will look natural. So it's hard for me to have that discussion because they've been tainted so much by bad plastic surgery, like, that you just see fake things and they think that they can control it. Realistically, if a patient comes into you, they're in your playground now, they can't control anything. They've trusted you and you're going to do whatever, the doctor does whatever they're going to do. You have to look at their behavior. You have to look at their patterns. And the only way to know a doctor's pattern of behavior is that you go back and you look at their photos.
Right. And that's kind of the key. I think when you're looking, I was doing an Instagram live earlier today. One of the patient's question, or one of the people's questions was, how do you go about choosing a surgeon? And I said, there's a whole bunch of things, in terms of credentials and their education and personality and everything else like that. But really, before and after gallery, I mean, that's where the proof is. You see what their style is, what kind of results they're getting. And if you see like 2 or 3 photos, then I don't know that you can make much of an assumption about what the work is. But if you see hundreds of photos consistently showing good quality results and a natural result, that's kind of the type of surgeon that you can probably trust to get a good result for you as well.
So one of the big benefits I see of finding a surgeon who does natural work, and again, it doesn't mean they don't do substantial, big, giant changes.
Absolutely.
A surgeon who does natural work is going to keep you looking good in the long run. So when you're looking at longevity of results and how you're going to age more appropriately, more naturally, and look better for longer periods of time if something was done naturally, because it fits the anatomy of your body.
Absolutely.
And so I see this a lot with faces. I mean, if you could tell me how you see it in the body.
Yeah, I mean, you don't want to have like a one size fits all approach to surgery. There's a surgeons who just do a few techniques and they try to squeeze or shoehorn every single case into that range, and that's not the best way to do it. So if you have a limitation on what you know how to do, your tendency is to say, well, let's do it the way I know how to do it, even if that's not the appropriate surgery. So like an example would be surgeons that I've seen who aren't particularly good at breast lift. So they see a patient with saggy breasts, they're like, oh, well, we'll just fill it up with a really big implant and that'll take care of the problem. Well, that doesn't take care of the problem. All that does is takes a small droopy breast and makes it into a big droopy breast. So you need to, I mean, I see this all the time where you have these like big implants that are too low. And the correction should have been either no implants with a lift and maybe some fat grafting, or a more modest size implant, but the lift is the key component there. So if the surgeon isn't comfortable with lift techniques, then they're not going to get a good result, and the patient's not going to even be offered the proper surgery. And you can cover that to anything. Like patients who need a tummy tuck, but they're offered liposuction instead, for example, when they have loose skin. That's not going to work. So you have to choose the surgical technique to fit the patient's anatomy, to fit the problem, and to fit what you're trying to achieve. And if you don't have the full range of techniques, you're not going to be able to get the results that every patient needs. Maybe it'll work some of the time for the patients that happen to fall into that technique range. But if you don't have the other options for that patient and they still go to you, they're not going to get great results. So that's like, for me, I made the personal choice to not do a whole lot of face stuff because I really wanted to get extremely specialized in the breast and body and be able to do anything that walks through the door, just like for you, that you can do anything with the face. And so that's why it's like a nice combination to have the two of us, for example, to be able to cover the entire body, not be sort of kind of good at everything, but be really good at like a wide range, but in your specialty area.
Yeah, and I think the thing that people need to be aware of is plastic surgery is not perfect. There is no chance that it's perfect. That's why we have revisions in this world. That's why people have repeat surgery and consent forms and all these things, because complications can happen. Things can go a little bit sideways, even if you're able to fix it. So the key thing that I tell everybody is how I guide what I do in my practice is I don't do anything I can't fix. What I wanted to talk about next was I don't know much about breasts as far as surgery goes.
Yeah.
In the world of breasts, as funny as it sounds, I'm more of an admirer. Like I kind of, I have personal experience and not much medical experience.
Fair
enough. What I try to guide people towards, and this is before I met you, is finding the right surgeon. And I'd look at their photos and I try to find really what's making these natural. And in the end, the answer is that the surgeon is. It's not the technique or anything like that, because some people are really fixated to techniques. They think that you go to somebody who does over the muscle, somebody who does under the muscle, or access points, that it makes a big difference. So what's the reality of the difference between access points, meaning incisions,
Right.
and then over muscle, under muscle, the positioning of the implant. And this is just for augmentation. I'm
Okay, I
talking.
was going to ask, not with mastopexy. Okay,
Right.
so for
I don't know
incision,
what that is, but yeah.
yeah, for breast lift. So for incision techniques, there's different ways to put implants in, but most surgeons are gravitating towards one technique now for breast augmentation because it's been shown in studies to be the safest. So you can go in through the areola, through like halfway around the areola. You can go in through the armpit. Both those techniques are fine, but you're going to be going through milk ducts in the areola or glands in the armpit, and studies have shown a higher rate of bacterial contamination, which doesn't usually lead to infection, but it can lead to bacterial biofilm, which can get on the implant. And since the implant's a foreign body, your body can't clear it, and that can lead to an inflammatory process that can create tightening of scar tissue around the implant called capsular contracture. So if you ever see a patient who has these like tight, hard-looking breasts or distorted breasts, that's usually what is from, and the rates are higher with axillary or areolar approaches. The inframammary or under the breast crease approach is going to be the cleanest way to put the implant in because you don't have to go through much to get right up under the muscle or under the breast tissue if you're going over the muscle. So it's a better way to put the implant in. The way that some surgeons did in the past, the tuba, which is the transumbilical going through the belly button, I don't know of anybody who does that. Maybe there's some people doing that. I think it's a terrible technique because it's saline only. You're doing a long tunnel from the belly button into the breast, and you don't have any control. And control is what gives you results. So if you have good control of your pocket, good control of your muscle, that's what sets you up for success. And if you're just kind of stretching out a pocket or just running your finger in there or using a long device to create a pocket, that's not a controlled dissection. That's where you're going to get into trouble. So incision wise for breast augmentation, I think it's pretty clear that evidence points towards inframammary incision as the overall best way to put the implant in. And then as far as over and under the muscle, when you say under the muscle, people get confused sometimes because it's not totally under the muscle. Your pec muscle kind of runs like this. And so if this is the implant, the muscle is covering the top and middle part of the implant, giving you a more natural slope in the upper breast, better looking cleavage in the middle. It gives you sort of a more blended look, more soft tissue coverage over the implant, lower risk of capsular contracture in a lot of cases. So there's a lot of advantages to that. Potential disadvantages of going under the muscle, you can get animation deformities where patients flex their muscle and it causes distortion. That's pretty rare, but if somebody's like a bodybuilder or somebody who does a ton of chest workout, that might be a reason to consider going over the muscle. That's the main issue, and then a little bit more soreness after surgery. So really, if you don't go under the muscle, you can do under the fascia, which is the connective tissue covering the muscle, or you can go just under the glandular tissue. Some studies have shown higher rates of capsular contracture with that. And especially if somebody has thinner tissue or not a lot of natural breast tissue, that's going to be a riskier surgery because you're more likely to see the implant and have rippling and other problems. So most surgeons do dual plane, which is partially under the muscle, but some surgeons get very nice results going subfascial or subglandular. So it's not a one size fits all. There's different options for patients.
Okay.
And you're asking about achieving a natural result, and I think it's implant selection is one of the key ingredients there. So it's not about just telling the patient, hey, what size do you want, and just stuffing that implant in. It's a thoughtful process where you have to measure the patient, you get a sense of what they want, how strong their tissues are, what the size of the breast is, how much the fold might need to be lowered, and then you're picking a range of implants that'll work. And then, if patients want to be bigger or smaller, you kind of work with them to a certain degree. But if somebody wants to be significantly bigger or smaller than what fits their body, I would generally turn them down because it's a setup for failure if you don't put a properly sized implant in the patient.
Moving towards breast reduction, which I think is breast lifting, breast reduction, which falls into my mind a category where you're committing a little bit more to incisions around the breast.
Yeah.
Does that change your threshold for doing a surgery on somebody? Like, do you throw somebody as quickly into the larger incision surgeries versus the smaller ones?
Yeah, so for me, in general, the incision selection is not like, oh, how do I get away with less scar? I'm always looking at what's going to get this patient the best end result. Because if you have less scar, but you have like a breast where the implant's here and you have some droopy skin hanging off the bottom of the implant, you've done that patient a disservice. It actually looks worse after the surgery than it does before. So really, the patient's anatomy will dictate to you what is needed to get the best end result. So for me, I'll usually be able, now there are patients in gray areas where you're not going to be 100% sure which technique works best till the implant's in place. And for those patients, I'll say, well, those are our two options. We'll see how things look with the implant in place. I'm willing to compromise a little bit. Like if a patient's really worried about scars or has a history of bad scarring, and I can get a very reasonable result with a lesser scar technique, for example, just a circle scar on the areola versus like a lollipop where you have a circle and a line going down the breast, I'll keep that as an option. But for some patients, it's very clear cut. They need a full breast lift. And if they don't, they're going to get a bad result. So those patients I'll either do them with the proper lift or I'll just tell them don't do the surgery. But I won't do sort of a half-ass surgery where you put an implant in and do like the wrong tightening and then you have a weird looking breast. It just doesn't work. So but ultimately the scars for most people fade nicely, but it's all about getting like a really proportionate youthful breast with a nice angle in the upper breast, nice curve at the bottom. The tightening technique is to drive the breast towards this sort of ideal shape that people want, which is a youthful breast.
And have you found a way to cheat this in any way? Meaning, like I've seen internal pexies and threads, heat-based treatments. I've seen a bunch of different things that people do to give the idea would be to give a slight amount of lift while doing an implant rather than doing a full reduction.
Yeah, so obviously there's differences. So like if we're talking about a mastopexy, which is a breast lift, you can do a mastopexy alone. You can do a mastopexy with an implant if you need more volume, or a mastopexy with fat grafting. A breast reduction could be the same scar technique as a mastopexy, but you're removing tissue and rearranging the natural tissue to create a smaller breast than because if you're starting too large. There's ways to kind of maybe cheat it a little bit. But in reality, like if somebody has a significant amount of skin overhanging the crease of the breast, if you don't do a full lift, either a lollipop or an anchor scar, depending on the situation, you're just not going to get the same looking result. And the result will be suboptimal. And so they may look fine in a bra or a bathing suit, but as soon as they take the bra off, something looks funny. If you have volume here with skin hanging off the bottom, it doesn't look good. It looks worse. It looks unnatural, and you can immediately tell something's wrong. So in those cases, if you try to cheat it too much, you're just doing the patient a disservice. As a matter of fact, in a lot of cases, I'm actually debulking some of that breast tissue at the bottom to keep it from hanging off the implant. You want to create a nice tight framework around the implant. So you can think of the implant, the muscle, whatever volume you're adding as the internal frame, and sometimes reinforcement material to help stabilize the implant. And then you can think of the skin envelope as sort of like the covering. So you're really creating the framework first, and then you're tightening the covering to fit that framework.
And for abdominoplasty or tummy tucks, I treat a lot of scars, and the worst scars that I've seen are the ones where they're really bad atrophic scars that have kind of stretched out and the belly button gets all distorted.
Yeah.
And I've seen those with really like short scar type ones. And then I've seen them with long too. Most of the time I feel like from what I've seen, it's the shorter ones that really get hypertrophic and thicken. But what do you think about kind of incision length? Are you doing anybody a favor by making a shorter incision for a real abdominoplasty?
Yeah,
I don't like distorted belly buttons. They're not very sexy.
Yeah, no, I agree. So the belly button is probably one of the key components of a tummy tuck, because if you can create a natural, youthful appearing belly button, that's sort of like a focal point of the abdomen. So, when I see these patients with these big stretched out belly buttons, obviously that's not very good. How good you can get a belly button to look partially dependent on what you're starting with. Some people are very stretched out from pregnancies, and you can make it look better, but they may have a lot of damage. Or you have patients who've had like piercings where the skin has been stretched out. But for the most part, there's a lot of control over what belly button shape you can get at the end. I think the main scar, the lower scar, what you're talking about, that's kind of the key. And I think there's two misconceptions. One is, a shorter scar is better. That's not necessarily true, because the shorter the scar this way, the less tissue you can take out that way. So as you start taking out more tissue this way, you need to create a longer incision this way so you don't get a dog ear on either end. Dog ear being a little bunching of skin. So I always tell patients that the length of scar, if you have a scar this long or this long, you're going to be covering that scar either way. So it's better to have a more tightness and a better result and have a little bit longer scar than try to keep the scar short and compromise how much you can tighten the abdomen. The real key is where you're setting that scar. So the biggest issue I tend to see with revision tummy tucks are surgeons that set the scar too high. And now when the patient's walking around, they have like you really want the scar basically right at the top of where the pubic hair would naturally be, or even slightly lower, so they can wear low cut jeans or low rise jeans, or a low bathing suit, and they won't see the scar. If you try to put the scar too high, then you're going to have to wear high waisted pants or high shorts. And what that line does is that sort of defines the length of the torso. So if you have a high scar, then it makes the torso look shorter and it makes the patient look shorter waisted. So again, the key is setting the scar low enough. The length isn't as big a deal. It's just making sure the scar is in the right position. And the biggest problem I'll see for revisions is where somebody has all of the skin laxity taken out, but then the scar is set too high and you have no more skin to stretch. And it's very difficult to lower that scar in that situation. So sometimes you can re-elevate the entire thing and only get to shift down another inch, and that's the best you can do. But the real key is putting it in the proper place in the first place.
Right. So I think as long as incisions are like anatomically logical,
yeah,
you end up
and also following a gentle curve. So like with a tummy tuck scar, you want it to just follow sort of just like where your jeans would ride, like a low rise jeans, just a nice gentle curve like this. You don't want like a weird W-shaped scar or a scar that kind of comes up in the middle. Or I've seen some really strange looking scars or scars that ride up very high on the sides that people can't hide. So it's all about being able to hide it with like a regular bathing suit or a regular pair of underwear.
Yeah. So what I experience with scars is mainly with lip lifts and facelifts, because that's what people worry about the most. And the worst scars I've seen actually from lip lifts are short incisions, and the worst I've seen on facelifts are excessively long or short incisions. So the ones where they made kind of the logical incision that everybody else makes, they tend to heal a little bit better, and there's a good reason for that. When you go and cut just a limited area and try to make a short scar facelift, or you do a long one that goes past where you can actually lift in the proper vector, you end up scarring because there's too much tension in the wrong area.
Not to say, it's all about distributing the tension evenly, and that's what's going to create a nice scar. If you have too much tension, that creates scar hypertrophy or thickening. And it's the same thing with any kind of surgery. If you don't distribute the forces properly, you're going to set the patient up for potentially worse scarring than they could get naturally.
Yeah, and this is a message to doctors and a kind of quick note to patients that the doctor you go to will determine the scar you get, not the incision that they tell you they're going to make. Okay.
That being said, also there's a genetic component to everybody's scarring, right? So, I always tell patients, like, I always put in 100% effort for every single patient. It's not my nature to do anything less than that. I have some patients with better scars, and I have some patients with scars that are not as good as those patients. And the key factor for most of those are just the genetics, So you can do the exact same stitch work, the exact same distribution of tension, and some people will scar better than others. But, it's imperative for us to do everything possible that we know to minimize the scarring make the scarring as good as each patient is potentially capable of getting.
And, I'd say in general, for patients who don't know what they're looking for, the thing to be cautious of, if lots of surgeons promise you little tiny scars in places that you see everybody else makes normal scars, that's where I see a lot of problems for like lip lifts, where they cut just here, not over there, or faces, or if they put cuts all over the place.
That's probably the worst. But yeah, I agree. I think it's less about the scar and more about the shaping. It's more about getting the ultimate aesthetic result. And if it requires a little bit more scars to get that, then that's what we're trained to do, is hide scars as best we can in anatomical features.
Kind of like we discussed with what's your threshold for doing a breast lift or something with more incisions? What's your threshold for doing a tummy tuck versus heat-based therapies? And I want to ask you, because you're mainly surgical, but you have a lot of experience seeing the minimally invasive, non-invasive stuff. So how do you guide people in general, like, if, without seeing a photo, how do you guide people as to what the reality is of each and what they would actually need?
Right. Well, a very common thing that happens for, I think, all plastic surgeons is you have a patient who comes in for like a abdominal liposuction consultation. And then as soon as you see them, you realize this is not a liposuction case. This is an abdominoplasty case. And then the patient has to be educated as to why you can't get away with liposuction. So the most common reason that people need a tummy tuck is pregnancy, because what happens is that as the abdomen expands and then shrinks, and multiple pregnancies, even worse, or twins, where it's doing that over and over again, you're basically stretching and damaging the tissue layers, one being the skin, so you can get skin laxity and stretch marks and things like that, and also the deeper layer of tissue, which is the fascia or connective tissue around the abdominal musculature. So if I have a patient that comes in and they have a bulgy abdominal wall where they look like they're a few months pregnant, or I've had some patients who literally look like they were 8, 9 months pregnant because they had so much laxity. Those cases, sometimes there's not really a skin issue, it's the abdominal wall issue. The only way to repair that is to release the belly button from the skin, make that lower incision, lift everything up, and then do muscle tightening from the rib cage all the way down to the pubic area internally to bring those muscles back together again in their natural anatomical position. That will create the waistline again. If you look from the side view, it'll flatten their abdomen down. It'll create a really nice appearance. If you try to do anything but the muscle tightening, if you try to get away without the muscle tightening, if there's loose skin, you'll still have that bulgy abdominal wall. So for those patients, they definitely need a full tummy tuck. For patients who have a lot of skin looseness, and I'm talking about not just below the belly button, but above the belly button, then if you start trying to just do heat-based treatments or liposuction, all you're going to do is create more laxity. Or, another thing, people come in is like they want a mini tummy tuck. Well, a mini tummy tuck.
I was going to ask you about that.
Yeah.
So I might need one after this Corona thing.
Yeah, well, with the food post you've been putting up, I wouldn't blame you. So
what is it?
So basically, what people usually get confused about is that they think a mini tummy tuck's a little scar and a full tummy tuck's a big scar. Now, mini tummy tuck scars are usually a little bit shorter, but the real difference is that a mini tummy tuck sort of stops dissection below the belly button, and a full tummy tuck continues all the way up to the rib cage, kind of where the abdominal wall stops and the rib cage starts. So for the patients who are good candidates for mini tummy tucks are people who look really good from the belly button up, but they have maybe a little bit of bulging below the belly button or loose skin, maybe from a C-section scar where they have a little overhanging skin, and you just kind of pull that skin down below and it looks really good. So the way a patient could even tell at home is if they just grab the skin just above their pubic area and just pull down with their fingers, and they're totally happy with how that looks, they're probably going to be okay for a mini tummy tuck. But if you have looseness of skin above the belly button, you need to release the belly button and re-drape all of that skin so it looks smooth and flat. Otherwise, if you do a mini on them, they'll be tight down below, loose up above, and that looks, again, unnatural and strange. So it's one of those situations where, sure, there's more scar, but it's not a huge difference. You have a circle scar on the belly button that you wouldn't otherwise have with a mini, and the main scar is maybe a little bit longer. But in exchange for that, you have access to the muscles to do all that muscle tightening and create the flat abdomen and better waistline, and you can re-drape and redistribute all that skin so that the belly button stays where it's always been, and that skin gets pulled down, the belly button will come through a new belly button hole, and all that loose skin at the bottom of the abdomen is removed. So it's the full tummy tuck is a much more dramatic, powerful technique. You use it in most cases when patients have had pregnancies, but there are some situations where, like I said, if they look great from the belly button up, a mini tummy tuck might be appropriate.
And do you have patients who have come to you in LA? I see this a lot where, in my opinion, they don't look bad enough to really have surgery or a tummy tuck like that. What situations have you seen where they come in and you tell them, hey, don't listen to that other doctor that you saw, just go get like something very basic and minimal for now, and then
so there's a lot of gray area cases where somebody will come in and they look great standing up. Then when they sit down, things look a little bit loose or bunchy. Their abdominal walls may be slightly loose, but not very loose. And overall, they're not too unhappy. Those are the cases where, is it worth re-elevating everything, putting those incisions, doing the big surgery where it's going to be a long run for a short slide, right? You don't get a huge improvement for a lot of surgery. Those are the cases where I would say, okay, we can do a tummy tuck and I can get you improvement, but the improvement's going to be moderate relative to the amount of surgery you're going through. Maybe you could try like body tight, or you could try like, RF microneedling or something to just get a little bit of shrinkage of the skin and see if you're happy enough with that, or maybe a little bit of liposuction in combination with those if it seems appropriate. So technology, year by year, technology is improving. I don't think there's no technology that can take the place of a full tummy tuck when somebody needs it. But for those gray area cases, that's where the technology, I think, has its place.
And tummy tucks, I think, like facelifts, I try to tell patients, if you're going to do it properly. You can't go in, just cut out a piece of skin and close it just because you're trying to do a mini tummy tuck. It's going to distort things. So if you're going to do it properly, there's no shortcut. And they try to say, well, I want a mini lift. I go, well, the mini version, or what people do, it's what produces the biggest scars. So, I always try to warn patients of that. They show me before and after photos, and the before and after photos are always kind of confusing on tummy tucks because patients aren't looking at the right things. They're looking sometimes at the lipo that was done. Sometimes they're missing the massively distorted belly button, which means there's really bad tension on it, or the incision has been covered up completely in every photo. So how do you think, patients should discern between like good surgery and bad surgery with their before and afters for abdominoplasty?
Well, I don't think it's necessarily a big deal if the scar is covered up in the photos, but you need to see where the underwear is riding. So if everybody's wearing like really high underwear, then you have to wonder, are all the scars really high? If the underwear is really low, or you'd normally wear a bikini, you can't see the scar. That's going to show you, hey, I'm going to be out on the beach in a bikini, and I'm not going to see that scar. And obviously, surgeons can show you what the scars look like at the office if that's how they do it. I think what you're really looking at with a tummy tuck is balance. You're seeing, is the upper abdominal area sort of balanced with the lower, or is there kind of like a weird bulge in the upper abdomen? Does the patient have kind of like a nice waistline? Is the belly button in the proper position? Does it look natural? Do things look kind of shiny and too tight, or do they look loose and kind of wrinkly still, or does it have that sort of soft, natural look? Do you have sort of the natural definition where you have sort of a center line and sort of you can see the sort of a little bit of muscle definition, which you can get on more athletic patients? So those are the keys. I mean, really, when you're looking at a before and after result, does the end result look natural? Like if somebody walked by on the beach looking like that, would you immediately say, oh, there's somebody had a tummy tuck? Or would you just think, your eye doesn't really pick up on that because they look normal? And then, another thing you have to keep in mind, obviously, is not every tummy tuck is going to be the same, because not everybody's anatomy is the same. So you have some patients who have very wide rib cage, wide hips, and the distance between the rib cage and the hips is very small. You're not going to be able to get that hourglass look in those patients because there's no room to tighten things in. The bone is kind of blocking it. You have other patients who have like a longer torso naturally, and you can really get that nice curve. So certain patients are going to be easier to get a more dramatic result on, or more, let's say, beautiful result on than other patients based on that. And then also there's a degree of improvement. So you have some patients who have just flaps of skin, like massive weight loss patients, where their end result, if you compare it to somebody who had maybe a couple pregnancies, may not look as nice. But if you look at where they started with like just reams of loose skin hanging all over the place and stretch marks and stuff, and you can get a major improvement there, then that's a great result. So you have to factor in all these different variables when you're looking at before and after photos. You can't just purely look at the after photo. You have to sort of see where they started, what was their starting anatomy, where did they finish, and is the end result still a natural, beautiful look for that particular patient's anatomical features.
And is there anything, for both tummy tuck or breast, is there anything that you would tell patients to look for that has bothered you in other surgeons' photos? Like when you see the consistency of them, or, anything that they do kind of to trick the eye, or things that don't show the real result?
That kind of drives me crazy. I see it more with breasts than with tummy tucks, but I do see it with both. So with breast, one of the things that drives me nuts is before photos with the arms down, after photos with the arms up. That is completely deceptive, because for any patient with semi-droopy breasts, especially if they have an implant with breast tissue drooping off the implant, if you raise your arms up, it makes the breast look dramatically better. So if you don't have consistent before and after positioning, that's not a good comparison. The other thing would be like if you see a before-after photo where the before the patient's standing and the after the patient's lying down, that's not a good comparison photo either. I mean, if you want to show like an immediate on the table result, and like, okay, great, but that's not really how you're going to compare or judge how the result looks. You have to have a consistent lighting, consistent positioning, and consistent views. So everything looks before and after the same, and then you can really judge what the difference is. And same thing with clothing. You want to make sure that, that they're not like hiding a high scar with high riding underwear, or patients. The other thing I don't like is when you have like a before photo that's sort of like a surgical style, in the office picture, and then the after photo is the patient in lingerie, like twisted in a weird position. That's not a fair comparison either. I mean, it's great. You want to show your patients happy and wearing clothes that they weren't comfortable wearing before. Fantastic. But that's not, you can't compare the before and after and say, okay, I can judge that result based on this photo. It's got to be consistent, like photo studio in your office, before and after, exact same position as close as you can get it to, and similar clothing or not clothing to show those results. So that's the kind of stuff that it's just like, I think with facelift surgery, it's like when you see the before, they're looking disheveled, and the after, they have full makeup and their hair is done up and stuff. That's not a fair comparison either. It's got to be consistent.
I think we covered a good amount. There's a lot of questions that people have. We'll just go over a couple of them,
Sure.
if you don't mind. The question that was repeated the most was about the guideline they've heard of changing breast implants every 10 years. Where does that come from? Does every surgeon adhere to it? Does it make any sense to you?
That's actually not a guideline. So that's a misconception. So a lot of people come in, they're like, oh, my implant's in for 10 years. I heard I have to get them switched. That's not true. There's no expiration date on implants. Conversely, if a surgeon tells a patient, oh, once we put your your implants in, they're good for life. That's not true either. There's not a specific expiration date for implants. They're not meant to last for a lifetime. At some point, they will rupture. But usually, if there's going to be a need for redoing the breasts, it's usually the patient's tissues that's the weak link, not the implant necessarily. It's a weak link.
The other question that a lot of people were asking was if you have any preference between gummy and other implants.
There's no true gummy bear implant. That was, as a matter of fact, it's kind of funny. So I did my fellowship in 2004, 2005 with Grant Stevens in the Marina, Marina Del Rey, California. And he coined the term gummy bear implants, referring to, at the time it was Silamed, now it's called Sientra. And it was a textured round implant that we're using a lot of at that time on an experimental protocol. And he called them gummy bears because they had like a more cohesive gel. These days, we're into like 5th, 6th generation implants. They're all more cohesive gel. So if you cut an implant in half, it's not going to run or leak out. It just kind of looks like a little bit like a gummy bear. But gummy bear is a little misleading because if you really eat a gummy bear, they're pretty firm, and the implants are still very soft. So they're not firm like a gummy bear, but they have it's just to kind of give the patients a sense that the gel is cohesive. It's not going to leak everywhere. So there's different brands with different levels of cohesiveness within the brands. I have my own personal preference in terms of based on data. So I tend to use Sientra, which is one of the 3 US FDA approved implants. The reason I like that particular implant is because the strength to softness ratio is the best of the 3 implants, and their rupture data and everything else is very good, and their warranty is the best. So for me, I feel like the data points to that implant, in my opinion. But there's nothing wrong with with Allergan or Mentor implants. A lot of surgeons use those. I could do a 2-hour talk just on implant selection, why you choose smoother textured or saline or silicone, and which profiles and which sizes and stuff. Generally, I think silicone for sure is going to be a better option for patients than saline because they're more natural feeling, they're softer, they blend with the tissue better, they interact with the tissue better. So I always tell patients, if they're asking about saline, I'm like, well, you could put a tape cassette recorder in your car and play music on it, but nobody's going to do that because, it's outdated technology. So for me, saline implants are kind of an old-fashioned implant that was good in the 90s, but in maybe the early 2000s. But these days, I've been using silicone consistently since they're available. Picking a good device for the patient based on surgeon experience, I guess.
All right. And is breast implant illness a real thing?
So breast implant illness is a very complicated topic. Here's my thoughts on this. I do think there are patients who have breast implant illness where their implants are giving them issues and making them not feel well. The real question, though, is what exactly is it that's causing the problem? As physicians and as scientists, we kind of learn just because B follows A, it doesn't mean that A caused B. You can have 2 things that happen and one doesn't necessarily cause the other. So in some cases, when some people are complaining of fatigue or autoimmune disease or other stuff, and they happen to have implants, we don't know that the implants cause that problem. A case in point was one of my own patients many years ago who was scheduled for breast augmentation. 2 or 3 weeks after her surgical date, she was diagnosed with psoriatic arthritis, which is a type of autoimmune disease. The catch in this situation was that for reasons I don't remember, her surgery had been rescheduled because I think it's some kind of conflict in her schedule. So she didn't actually have the surgery 3 weeks before her diagnosis. If she had the breast augmentation, she told me 100% she would have blamed the implants on her autoimmune disease because that would have been the biggest new factor. So it just goes to show in that situation would have been a coincidence. Now, if with breast implant illness, my best guess right now, just so you know, plastic surgeons take this very, very seriously. We have a new task force working on it. We're doing major studies right now to see what's causing people to not feel well, what's the connection there, and to try to figure this out. But if I had to guess right now, my best guess is it's not the implant itself necessarily, but the fact that you have a foreign body, you can get a biofilm of bacteria, and that can create an inflammatory state, which in patients who are maybe a little bit more sensitive can make them not feel well. And once you take the implant and the scar tissue out, you're removing the potential biofilm and making them feel better. So that probably, in my mind, would be the most likely culprit. Could there be something in certain patients that are just not reacting well with the implants? It's really hard to know. So on the BII situation, basically the way that I and most plastic surgeons feel right now is that we listen to patients. If they're having problems and they want their implants out, it's absolutely their right to do it, and we're happy to do it for them. But they also need to understand that in certain cases, you can have these problems, take the implants out, and you may not feel better, and it may not have been the implant. So it's a very tricky subject. I think the key here is good communication with patients, listening to patients, not saying, oh, this person's crazy, because I've definitely met some people who clearly had their implants out and felt better afterwards. Some of my own patients, but I've met some other people's patients too, who are very credible. And so I don't think it's like a myth. I just think it's like, it's very easy to have these sort of nebulous symptoms, and not all of them can necessarily be blamed on implants. So we have to be careful about applying a lot of science to this and trying to be as factual and scientific in our way of looking at this as possible. And so, like I said, the societies right now are taking it very seriously and they're looking into this heavily.
It seems like it's inconclusive at this point.
Let's put it this way. I think it's in the works. We're kind of in the process of studying it even in more depth. And I know there's been a lot of resources right now that are being applied towards studying many, many different aspects of what it could be, like heavy metals and this and that. Every meeting, there's conversations on BII, on ALCL, which is the type of lymphoma that's associated with textured implants. The meetings, it's not just surgeons. We're bringing in patients who are advocates and have had these issues themselves to talk to surgeons, because we don't want surgeons to be saying, oh, these are crazy people. We want them to take these patients seriously. We just want to study it the proper way, just like we do with everything else.
All right. So I think that's all the questions we'll go through. We'll do another talk definitely soon.
That'd be awesome.
All right, buddy. I'll talk to you soon.
I'm looking forward to it.